It was not that long ago that Medicare advocates openly pondered what we all did with our time before the rollout of the Part D prescription drug benefit. The last few weeks and months have conjured similar feelings in that many individuals and organizations in this room went all in an effort to try to protect the Affordable Care Act, the Medicare, and the Medicaid program. Now that we have at least a partial reprieve, we know it's not a permanent reprieve, and as we discussed this morning, there are many threats on the horizon, but there's a pause, which would be a good time to stop and try to remember what we were all working on and thinking about a few short months ago. There are still barriers to care in the Medicare program. There are still hurdles to obtaining due process to redress one's grievances. There are still challenges and pitfalls for people who are transitioning into Medicare coverage, and there are still things that Medicare should but is not required to cover. This panel will spend a little time addressing some of those issues. I am honored to facilitate this panel of outstanding advocates and leaders. Their full biographies are in the packets, but suffice it to say, they all have letters after their names and have had distinguished careers, including their current ones. We're going to start with Alice, or as we referred to her, Allie Bers, our litigation director here at the Center for Medicare Advocacy. We will move on to Joe Baker, the president of the Medicare Rights Center. Then we will hear from Michael or Mike Alfano, which we will call you, I guess if we want to scold you, Michael, if we want to be chummy, call you Mike, who is the president of the Santa Fe Group and professor, dean, and executive vice president emeritus at NYU. I want to thank the Santa Fe Group for sponsoring this panel. And we will end with, as many things do, with Max Richtman, the president and CEO of the National Committee to Preserve Social Security and Medicare. That was meant in a good way. That was meant in a good way, Max. We have asked the panelists to discuss certain topics, starting with things that are still somewhat in play. And to that extent, Allie will talk a little bit about some of our litigation, including that related to the improvement standard and observation status and obtaining due process in the Medicare appeals system. We will then move on to Joe Baker, who will talk about some of the challenges and pitfalls of transitioning to Medicare, the notices that people get, and what in particular the Medicare Rights Center is doing to address that. And then we will shift a little bit to things that perhaps might require a heavier lift. And by that I mean expanding Medicare coverage. And Mike will talk to us a little bit about oral health in Medicare, and Max will talk about audiology coverage in Medicare. Again, I am honored to facilitate or moderate this panel. We work with all of your organizations and look forward to continuing to do so. Before I turn it over to Allie, I am going to start by just touching on a couple of these issues, largely to buy Allie some time because she had too many topics to cover all at once. So I'm going to cover a couple of them for them. I'm going to start with therapy caps in Medicare, which is a barrier by design. Medicare law caps the amount of outpatient physical therapy, occupational therapy, and speech therapy that it will cover in the outpatient setting per calendar year. There's kind of a two-level cap. There's one cap at $1,980 and a separate cap at about $3,700. This is not based upon the clinical efficacy or medical necessity of any care. This is based solely on saving the federal government money. We have seen these therapy caps act as a significant barrier to care for people, particularly people who have ongoing needs and have chronic conditions who could be benefited by therapy that goes above and beyond the cap. For example, we have some colleagues work up at Kennedy Krieger Hospital up in Baltimore, a very respected center that focuses on individuals with spinal injuries. They tell us that the process of fitting someone for a wheelchair itself will burn through the Medicare cap. There are there is a so-called exceptions process in place whereby if the provider makes certain assertions and certain paperwork is filed, someone can request an exception to this cap, kind of two levels. The first one is supposed to be an easier hurdle. The second one is more of a hard cap where there's a more intensive medical review. But this exceptions process, first of all, is expiring at the end of this calendar year. It's one of those things that's perpetually renewed, something that is often referred to as an extender that used to be attached to Medicare physician payment legislation. And two, the exceptions process is simply not working. Many providers do not want to go through the process, and quite understandably, that is because, based on our experience and what we hear from many providers, they are often not successful in getting Medicare contractors to process the exceptions. Last time Congress looked at trying to deal with the exceptions process, there was an attempt to repeal them altogether, but at that time the cost would have been about $20 billion over 10 years, not an insignificant sum. In an effort to reduce that cost, there were proposals to, instead of outright repeal it, to replace it. However, the replacement policy, in our view, could be just as harmful, if not more harmful, because it would impose prior authorization and give an extensive amount of secretarial discretion to impose additional barriers to care, and the cost is estimated to be about half as much, one would venture to guess, because there would be about half as much of care provided. So, wanted to flag that issue, be on the lookout. The exceptions process, as nominal as it is set to expire at the end of this year, will likely come up again. The second issue is an issue that I think many folks here are familiar with, is observation status. That is a designation used by hospitals to bill the Medicare program. We know it can have significant consequences for beneficiaries who are caught up by it. Increasingly, patients in the hospital are considered observation outpatients, although they have been cared for in the hospital for multiple days and often get care that is indistinguishable from people who are formally admitted as inpatients. There are a number of potential impacts on beneficiaries. The most significant is usually the fact that someone who is considered to be under observation status will not meet the 3-day prior hospital stay requirement in order to qualify for Medicare skilled nursing facility coverage. One of the criteria to qualify for skilled nursing facility coverage is someone must be an inpatient for at least 3 days. Someone who is considered under observation status is not viewed as such. This is a problem we have tried to tackle for many years in many different ways. In part, we work in a coalition of 30-odd groups, including many organizations in this room, to try to address this issue, from Medicare Rights to National Committee to AARP to National Academy of Elder Law Attorneys to American Healthcare Association to a number of other organizations. We have tried the administrative route. We have tried to convince CMS that they currently have the authority to essentially count the time spent in observation towards that 3-day prior hospitalization stay. Toby wrote a fine memo to CMS, which they so far have not agreed with or implemented. We have tried the legislative route, as we heard earlier today. Although Senator Brown did not say this, he has been the lead in the Senate on a bill. Joe Courtney has been the lead in the House on a bill that would count all the time spent in the hospital towards that 3-day prior hospitalization requirement, which would alleviate a lot of the suffering that comes about as a result of observation status. There was some federal legislation that partially addressed observation status. The Notice Act that was passed a couple years ago requires people to get notice that they are in observation status, but only in certain situations. The Notice Act really took effect. Hospitals were required to give this notice earlier this month. There are a lot of pitfalls and shortcomings there. I refer you mostly to Toby's writings on our website that talks about these things. And finally, we have tried the litigation route, which is one of the things that Allie will talk about. I will now pass it over to Allie. If you guys are more comfortable staying seated, by all means, please do so.
Okay, thanks, David. I'm going to be referring to a few cases, and I am told that the light blue sheet in your folder is where you can look for people who are interested in things like citations and looking up opinions. You can look on that light blue sheet. So I'm going to start by talking about Jimmo versus Sibelius, which is a class action lawsuit that we brought to address the improvement standard. That was brought by the center and also our co-counsel Vermont Legal Aid on behalf of individuals and organizations. Organizations included the Parkinson's Action Network, which we have a representative from the Michael J. Fox Foundation here today, which they're now part of, also the National Committee, as well as individuals who are affected by this problem. Lead counsel on the case, who has seen the case through right from the start up to the present moment, is Gilda Ford, who is here. Stand up, wave, yeah. Okay. And the lawsuit was brought to address a decades-old, very ingrained problem in which Medicare would not cover skilled nursing or skilled therapy, like physical, occupational, or speech therapy, unless the person was improving or making progress. So if you had reached a plateau or were considered chronic and stable, it's a phrase you often would hear, Medicare would the claim. Providers learned this, and accordingly, they would stop services or not provide services in the first place. Now, Medicare law does not require improvement. Skilled care or the supervision of skilled care may be necessary to preserve current functioning or to prevent decline. And I will use just very quickly an example from my executive director, Judy Stein's own family. Judy's mother, who is 90, is that right, is receiving physical therapy. And as Judy puts it, that ongoing physical therapy for her mother, which allows her to remain mobile and move around and walk around, is equivalent to her blood pressure medication, and that it's not something that you can just stop. It is something that is keeping her going and keeping her and maintaining her in the good condition that she is in. But unfortunately, the law has often been implemented incorrectly and to require improvement, and that has a disproportionately negative effect on people with conditions that by definition will not improve or go away. So that includes MS, Parkinson's, ALS, Alzheimer's. The case settled in 2013, and the settlement called for revisions to the Medicare Benefit Policy Manual. That's the sub-regulatory manual of the program that interprets regulations, as well as an educational campaign, and that consisted of transmittals, articles, national calls for adjudicators, contractors, and others who carry out Medicare policy about the clarifications. I am purposely using the air quotes like wiretapping, clarifications to the manual spelling out that there is no improvement standard. And the reason I use the air quotes is because that word clarification, which is something that CMS likes to use, wound up, we think, causing confusion, and I will get to that in a moment. But it has turned out that the legal victory in Jimmo versus Sibelius has been less difficult than the implementation of the settlement. So despite the manual revisions and the educational campaign, we kept hearing stories about inappropriate denials. We tried to work with the government, the Department of Health and Human Services. We asked for additional educational measures, but they refused to do anything more. And it felt like this settlement was being implemented, frankly, with all deliberate speed. It was not happening. So we went back to court just about 1 year ago with a motion supported by 24 declarations, around 70 exhibits gathered by us with assistance from many partners, some of whom may be here, demonstrating the continuing problem. And the court did find that the government had not properly carried out the education campaign and found that there was non-compliance with the settlement. The court ordered a corrective action plan, which the government now has until September 4th to implement. So we are waiting to see what happens there. The corrective action plan calls for additional education, as we had been requesting, as well as training measures, and a new web page on the cms.gov website that is devoted to Jimoh. One thing we've been saying is it's very important to have the CMS imprimatur on anything that new that comes out, because us saying it is one thing, but CMS saying it tends to mean something more to providers. So that will be on a website, and the website, all of the Jimoh-related documents that have been put out thus far will be there, sort of a one-stop shopping for all of your Jimoh-related materials, and it will contain a corrective action statement that affirmatively disavows the improvement standard. I'm going to read one sentence of that statement word for word because this one was important to us. The Jimoh settlement may reflect a change in practice for those providers, adjudicators, and contractors who may have erroneously believed that the Medicare program covers nursing and therapy services under these benefits only when a beneficiary is expected to improve. So this was very important to us because that term, clarification, which CMS had insisted on using, did cause to confusion as to whether anything had actually changed. So we've moved from clarification to change, and we hope that the corrective action plan will get the message across that CMS meant what it said. But so that is a positive step, but looking forward also, we know that many providers are still reluctant to provide and submit claims for maintenance care. Some of them have a not irrational fear of audit by Medicare. Some of them still do have a misunderstanding of the Medicare benefit. So a challenge looking forward is looking at that mindset that has to be overcome. A physical therapist told me recently that physical therapists are taught from day one of their training that it is their job to improve people, and that plateau is a bad word. So that is the mindset we are working against, and we hope that the corrective action plan in Jimoh will contribute to chipping away at that mindset, allowing people who are entitled to coverage under law to get the coverage that they need. Now, talking about observation, and thank you for setting up that issue for me, I will talk about the Barrows litigation, which is in the middle of the sheet. And this is also, a case was filed as a class action. It has not been certified quite yet, though a class motion is currently being briefed and pending. This case has a long procedural history, but now after being remanded by the Second Circuit, the case is seeking to establish appeal rights for hospital patients who are placed on observation status. So the notice that David referred to that is now, just as of a few weeks ago, being handed out, actually doesn't contain appeal rights, and the agency went so far as to specify in the regulations that this notice does not generate any appeal rights. So this is a really disturbing carve-out from appeal rights by beneficiaries, this placement on observation status. And I should mention that hospitals, they are not carved out. Hospitals routinely appeal Medicare denials of payment for inpatient claims. And in fact, that's been a major factor in the backlog of appeals at the administrative law judge level. But CMS has now explicitly said, and their lawyer said it in open court when we had a hearing in December in the Barrows case, that there is no way currently for a beneficiary to appeal the coverage of their hospital stay as an outpatient stay under Part B rather than as an inpatient stay under Part A, despite the sometimes dramatic consequences that David mentioned of that classification. So the center is pursuing this case, seeking to establish appeal rights with our partner Justice in Aging, as well as with incredible pro bono assistance from the law firm of Wilson, Cincini, Goodrich, and Rosati. And plaintiffs are making a constitutional due process argument for a right and method of appeal. The remedy would be simply for CMS to allow this particular issue to be addressed in their already existing appeal system. The structure is already there. People in the hospital can appeal if, for example, they think they're being discharged too early. There's a whole structure in place for appealing that. What we are seeking is for that to be extended to people who are placed on observation status, that they also are able to say that they disagree with that determination, or that they could use the standard after the fact appeal system to make the same argument, which, as I mentioned, hospitals do routinely. So when the agency claims, as they have in this case, this is not something that is an appealable issue because this is something that happens only in the minds of doctors and Medicare doesn't have anything to say about that, I think that is belied by the fact that there are thousands of hearings on this very issue as to whether a claim should have been billed as a Part A inpatient claim versus as a Part B outpatient claim when the appellant is the hospital. The case has raised interesting legal questions about due process, such as whether beneficiaries have a protected property interest in Medicare coverage. So the people who remember their constitutional law, that's part of what is required for a due process claim. And this protected property interest issue has generally been assumed but not directly addressed in the existing case law about Medicare and due process. We've spent the last year basically on the protected property interest question, and once the class motion is resolved, we will also be moving on to the other aspects of due process, state action, what process is due. So the case is moving forward. And if observation status is not fixed legislatively, which we hope it will be, but the hope is that at least this case would allow patients to challenge their placement on observation status and establish due process protections. Do I have like 1 or 2 more minutes? Sure. Okay, so just to very briefly then touch on the fact that what we're arguing for, sort of sadly in this observation status case, is for a right to appeal into an appeal system that is generally broken. And so we are also working on trying to improve the appeal system that we're arguing for, that people should have the right to use. Medicare appeal system in general is not functioning well. It's overwhelmed. At the lower levels of administrative appeal, it's churning out what we at the center have been calling rubber stamp denials, essentially cursory cut and paste decisions that don't meaningfully address the merits of the appeal. We are currently litigating that rubber stamp denial issue as a matter of due process, but I wanted to briefly discuss on one due process that does have a happy ending, and that is the settlement of Exley v. Burwell, which is the last case on the sheet. That case addressed delays at the ALJ, the administrative law judge level of appeal, which is the 3rd level. If you persist past those first 2 lower levels of appeal, you can get to the ALJ level where the appellant actually has the greatest chance of success. That settlement locks into place for 3 years the prioritization of beneficiary-initiated ALJ appeals. So if an individual beneficiary is appealing, as opposed to a hospital, a provider that actually make up the great bulk of appeals, that request should be put at the front of the line. And from the data that we're getting, the appeals that are properly identified as beneficiary appeals are in fact getting decided within, or at least very close to, the 90-day period which is established by law. There is actually, in the statute says that the ALJ decision has to be issued, all done, the hearing done and the decision out within 90 days of receiving the request for the hearing. Providers are another matter. They make up the great bulk of appeals, and they are still tremendously backlogged and delayed. They have their own litigation going with its own issues, but happily on the beneficiary side, the delays have been largely addressed, and on the sheet you'll see a couple of other aspects of the settlement listed there. There is a beneficiary helpline that's been established and a new ALJ hearing request form that makes it easier for beneficiaries to identify themselves as beneficiaries and get put at the front of the line. So that is a due process success story, and we hope we can build on it as we go forward.
Great. Thank you, Ellie. I forgot to mention at the outset, although we asked Joe, Mike, and Max to talk about a particular topic, we want to work that all of your organizations are doing beyond that. So if you are so inclined and time permitting, please talk about that and help us rally everyone in action steps on all the work that we're doing.
Well, I think that we're rallied. That's the good news. You know, this is a much different meeting today than we would have had absent the action that we all took over the last couple weeks. And I just want to commend us all in this room and many others who aren't here today that worked in concert really to achieve what was a defensive maneuver. And so it's a luxury to a certain degree to be able to talk about some of these, well, ongoing work, but that we can devote our minds and energies to again. I really do think it was an example of all of our organizations galvanizing not only our own constituencies, but larger public opinion and working well with our friends in government and elsewhere. So, I mean, I really think we all need to take a moment, a pat on the back, and re-energize, because, as we all know, it ain't over. But I also, before I said anything, I congratulated Ben on getting this wonderful award, and I wanted to just say to Judy and to others that, Chip, when I started out, when I was 10 years old in this business, Chip was an incredible mentor to me, as was Trish Nemore and Toby and Vicki Gottlich and you, Judy. So, it's a tremendous honor to participate in this summit, and particularly for this time with the first Chip Award, Chips Award. So I'm really thrilled to be here. So what I think is good about all of the work that you're hearing here is it's connected to real people. It's not like a made-up thing like, we really want to have this thing that nobody really needs, right? Hospital care and skilled nursing facility care, like home care, like dental care, like audiology. Well, you can't get any of that if you can't get enrolled into the Medicare program. Just a show of hands, and I know this is kind of a loaded question for this group, but because you help a lot of people, but how many times in a cocktail party or whatever have you heard, I need help enrolling in Medicare, I'm not sure how to do it, somebody screwed it up, I couldn't believe I got there at the last minute. Right, why? Why does that happen? It's every American, hopefully, is going to enroll in the Medicare program. There's already 57 million people in it. You'd think that some education would have been passed along by word of mouth, but it doesn't happen. And with the advent of the ACA, right, it kind of got a little worse, because people all of a sudden, we used to have, we all did, people gasping on the phone, can I enroll in Medicare early? Can I get in there early? And they're like, no, you've got to wait till 65. So they were on it when 65 came along, right? Then what happened? Social Security full benefits eligibility changed to 66. Now it's going to be 67, right? Well, the solution to that, as far as I'm concerned, is to make you eligible to enroll in Medicare at 62 when you're first eligible for Social Security. But that's not the way it's worked. Instead, we've had proposals to move Medicare eligibility up to 67. So we're not for that, as we know. So we developed a piece of legislation that Stacey Sanders here in our Washington office, and now working with Julie Carter, and many of you who have been so supportive of it, the Bennies Act, basically to do three things, which seem very simple, which we tried to get done in the context of administrative rulemaking, and Ben was pushing that that gigantic rock up the hill with us at Social Security, and it's because it's CMS, Social Security, and IRS, the Department of Defense, the CIA. No, I'm only kidding. The first three have to agree. Yeah, have to agree, and that's agree with 1G. On sharing information, to get a notice out to people. The bottom line idea is when you're 64 years old, you should get a notice from the federal government say, you got something great coming. Whatever president is president then can sign it, as far as I'm concerned, right? And instead, we have, people's lives have changed. You might hear something from an employer. They might hear something from an insurance broker. You might be waiting till 67 to retire, whatever. You might still be working. How many people have we helped that thought COBRA? You could stay on COBRA. I'm not on the government's dime. I'll save the government some money. And then they get into trouble because they wait till they're 67 or 68 to enroll in Medicare when they should have at 65. So the first thing is just very simple, getting a one-page notice similar to the Social Security notice that we all get, saying this is what you got coming and this is how you have to get access to it. Right now, we're a black box on the Social Security notice. We know the two pillars of financial security and retirement are health care and financial assistance, or income and health. And so we think we deserve our own letter. And like I said, my picture doesn't need to be on it, okay? And then the other thing that we know is that there's this kind of arcane and left over from the myths of policy, waiting periods for Medicare. Even if you enroll in your initial enrollment period, which is the 3 months before your 65th birthday month, 65th birthday month, in the 3 months after your 65th birthday month, you start to have waiting periods for coverage to take effect. We don't think that, that's not the way employer insurance works. If it still works that way at some employers, it shouldn't. You should have basically coverage to begin either retroactively in your 65th birthday month or, in the next month, the first of the month after you enroll, not wait 2 or 3 months out. And finally, in the general enrollment period, if you've missed your initial enrollment period, you have to enroll January through March of every year for coverage to begin July 1. Right? There's also a monetary penalty. We have people that will mortgage their entire houses to pay any penalty that the government might charge them to have coverage that begins February 1st. Because the reason they find out that they've missed it through no fault of their own is because they got diagnosed with something and they need that care. And these weren't gamers. These weren't people out there saying, ooh, I'm going to wait till I'm nice and sick in 82 before I sign up for Part B and I'll save that $100 a month, or that $125 a month. These are just people, and I guess there are gamers like that out there. They, I don't know who they are. I haven't met one yet. They don't call me or us, or they lie. But there's not, most of the people that we, talk to made an honest mistake. So we really do think that we keep those monetary penalties in place to give people the right incentives if they are going to game. Also, that would have scored for CBO, so we're trying to get this thing done. But we get rid of that time period, which actually scores as well. But I think we can get past that. And then finally, we're talking about appeals a little bit. Right now, if you miss these open enrollment periods or your special enrollment period, you get, and you were misled by an agent of the federal government, you can apply for something called equitable relief. And it happens in kind of, I don't know, room 105 or something. And so you get this equitable relief and you get on Medicare without a penalty and retroactively and or immediately. And while we don't want to create a whole big appeals process because we don't necessarily want it to go through this process, we think that Social Security can exercise this discretion. We think we need to make it a bit more transparent, and we need to make additional reasons, like you were misled by an insurance broker, for example. You were misled by your COBRA administrator, So there's a variety of ways you can make a mistake in this regard, and we believe that that should be grounds for equitable relief. So this is a bill that was introduced in the last Congress by Representative Ruiz, who's a Democrat from California, and Representative Meehan, a Republican from Pennsylvania. Yes, a bipartisan effort in the House, which we hope to replicate, and then by Senator Casey and Senator Schumer in the Senate. So for those of you that want to know more about it, you know where to find us, and many of you have already been incredibly supportive and will, I'm sure, continue to be so as we get information about it and its chances, where it's either will be done in the middle of the night with a lot of other sausage making, or it will be something that is pronounced as the Medicare reform of the year. I'd rather have it be the former almost, because that'll mean other things, hopefully good things will have been done, and this won't be the only thing that's done. But in any case, we're pushing this for a whole variety of reasons. And in addition, as I said, we're working with a lot of you and with a lot of states and with healthcare.gov and CSIO on making sure that people have easier transitions from ACA provided coverage from a QHP to Medicare, and that's appropriate for their individual circumstances. So thank you as well for your help in that, and happy to talk with you about those efforts. Thanks.
Thank you very much, Joe. And as we transition now from kind of ongoing battles that we're having to what some would characterize as more aspirational, or things that might be a heavier lift, that is adding benefits which currently are not covered under Medicare, and Mike is going to talk to us about oral health. I want to recognize the fact that this issue is gaining more traction, and that is reflected by the fact that we have some friends from the dental community here today. Dr. Mowden, Dr. Jones, Beth Truitt, folks from Oral Health America, DentaQuest, Santa Fe Group, to me, really reflects that this is an issue that is starting to resonate, that is of import, and hopefully is gaining enough momentum. Mike.
From your lips.
Thank you, David. And thanks for the invitation to be with you today. Judy, it was a pleasure to meet you last summer, and we've come quite a ways since that time. I'm here as a representative of the Santa Fe Group. Most of you don't know what that group is. It is a independent, not-for-profit think tank that focuses on oral health policy. We like to say we're the leading such think tank because we believe we're the only such think tank, so it's pretty easy for us to get away with that. We've worked on different issues through the years, but we are locked in now for the foreseeable future on working towards an oral health benefit for aging Americans. We like to compliment the CMA in particular for its work with the Dental Lifeline Network. The Dental Lifeline Network, do some very good work trying to arrange care for people with devastating diseases, people who need organ transplants and the like, and sometimes are denied the wherewithal to get the organ transplant because they don't have the money to pay for the dental care. And you can't be transplanted and be immunosuppressed if you have a raging infection in your mouth. So I'm going to do this very quickly. I'm going to divide it into two sections. One, why are teeth, why is the mouth important for its own sake? I need to do that because there are a lot of people in dentistry who are indignant that we have to justify our reason to be at a table like this because we believe we will generate cash, believe it or not, for other areas to spend money, and I'll explain that to you in the second part. So, oral health for its own sake. Mastication, you know about that. Food selection, initiate digestion, initiate the immune response, and also contribute to the hedonics of eating, make it more pleasurable, biting into a crisp apple. Speech, obvious, helps us articulate. But the mouth also forms a framework for the muscles of facial expression, and that's an important part of speech. The way you say a word and the way you express that word through the muscles of facial expression. Social acceptance, we've heard that talked about already today. And it's not just about beauty, it's about fresh breath, it's about confidence in your social interactions, it's about first impressions, it's about job interviews, it's about quality of life. So there's a lot of reasons that oral health is important for its own sake. There are also very debilitating and deadly diseases, like oral cancer. I suspect most of you don't know that oral cancer kills more people in the United States than either melanoma or cervical cancer. So there are deadly conditions that affect the mouth. Those of you who are readers of the New York Times would have learned about many of these things in the article that appeared this Tuesday in the Science Times. It's a wonderful article. I know most of the people who were quoted in it, but it only stays on why teeth are important. So it covers what I just did in like 2 minutes. So it's important, it's well done, it's incomplete. And I sent a letter to the editor about this, talking about the fact that they buried the lead. And the lead is that oral health is integrated to total health, and it's integrated in a way that if oral care is delivered, large amounts of money can be saved by the various federal systems that provide health insurance. Before I move to the second part, I want to have a shout out to the Gerontological Society of America. A few of us spoke there at a meeting they had last month. They are getting ready to make a presentation to this once every 10-year conference on aging. It's going to be held in San Francisco in July. And one of the key things they're focusing on is oral health. So they produced a nice document, and it's at the table in the front. All right. So what's the data set, and why should we be interested in oral health for more than just its own sake? Over the past 30 years, there's been about 10,000 papers, give or take, all of which focus on oral and systemic interactions, and most of which show pretty clear interactions between things like periodontal disease and diabetes, cardiovascular disease, stroke, end-stage renal disease, pulmonary disease, among others. But there are curious associations. Sometimes there can be an interventional study, and you will see an effect to lower hemoglobin A1C, for example, if you treat periodontal disease. But for the most part, there are no very large, well-controlled clinical trials that show these effects in tens of thousands of people, the kinds of studies you would need to convince everyone. I submit to you there was never such studies showing that smoking causes lung cancer. Yet everyone knows smoking causes lung cancer. It would be unethical to do a study of that type. So what is the nature of this data and what drives it? Let me point out that if you were to take all of your gum tissues, okay, and place them on a piece of paper, it would cover the surface area about the size of my palm, okay? Now, you don't tend to think of that. You think you have these little spaces between your teeth and your gums. The reality is, if you look at your entire mouth, it's a large surface area. And if that surface area was on your shoulder, and if it was exuding pus, and it was pumping toxins into your body, you would pretty quickly understand that it can have an impact on your general health. And that's essentially what periodontal disease does, okay? Not a pleasant thought, maybe, but, you know, for someone with periodontal disease, that's what's happening biologically. And, you know, I was going to get into a little biology, we don't have the time. More recently, we're starting to move beyond curious or powerful associations and move into cause and effect. And so in November of last year, the British Medical Journal published a study in which the authors concluded that periodontal disease is a contributory cause of atherosclerotic vascular disease. Contributory cause, okay? What does that mean? It means that not every case of atherosclerotic disease is caused by periodontal disease, and that you can have periodontal disease and not have that disease and not have periodontal disease. But in some people, periodontal disease is the causative agent that puts the individual into a crisis situation. The reason Santa Fe Group got very active in this arena is we became aware of a series of studies that were done on insurance data. So up front, insurance data, retrospective data. There were 6 of them. 4 of them were analyzed by a group called Avalier. It's a think tank in this region, this part of the country, and it's this document that you should have at your table. I encourage you to read it because it's going to go into a bit more detail than I'm able to do today. And the reason there are only 4 studies summarized in here is because the other 2 studies came after this work was done. Okay? What do those studies show? Those studies show that people who get periodontal treatment and have these other systemic diseases like diabetes, cardiovascular disease, and the like, they share an inflammatory component. And as you exacerbate the inflammation in the body, you exacerbate the systemic disease along with the periodontal disease. And large amounts of money are saved, not because hemoglobin A1C goes from 7.1 to 6.9, but because that diabetic patient is not as likely to be hospitalized for a diabetic retinopathy or a diabetic ulcer. And if you look beyond the total savings as to where the savings is coming from, it's coming from fewer hospitalizations and fewer ER visits. And it's not just ER visits for the dentistry, it's ER visits for the primary systemic condition. Now, let me dimensionalize this for you. Let me first tell you who did the studies. They were done by Aetna, Cigna, Kaiser Permanente, United Concordia. Sidebar about Kaiser. Some of you know they are now getting into dental on the West Coast. One of the reasons they're doing that is they're watching their data, and they're seeing how much money can be saved in their diabetic patients if they get dental care. United Concordia, United Healthcare, and the Health Policy Institute of the American Dental Association. Just take diabetes as one example. If you look across the range of these 6 studies, the savings are about, the low end is $1,300 per diabetic patient per year, to as high as $4,200 per diabetic patient per year. And the $4,200 figure comes from adding on the drug savings that aren't required in managing the diabetic. So, I pointed out that these are retrospective studies. We need to be on guard. That doesn't prove cause and effect. One thing you would suspect right away is, oh, it's very easy. The people who are conscientious enough to go and get dental care are conscientious with their systemic well-being. Except that the United Healthcare study concluded, and I'll read it, the largest medical savings were for members who were not medically compliant with their disease management program. So it was the exact opposite of what you would expect. And in fact, the dental care made those people almost equivalent. There were still savings to people who were highly compliant with their medical care. So it makes a real difference. Now, at least 3 of these companies, I'm going to name them, United, Concordia, Aetna, and Kaiser, have acted on this data prospectively. I believe the others have too, but I don't know that for a fact. I know it for a fact on these 3. Why? Because they've explained to me they have a new business model. And their new business model is to go partner with general health insurers, either in their own company or in other companies that don't have a dental insurance division, and show them the savings that are attainable. And then what they do is they work to get the patients in for dental care, primarily periodontal care, and they do so in a way they're calling the patients and they're waiving copays and they're waiving deductibles. So the periodontal care is free. That's how valuable they have discovered this to be. So here's the outrage. Private insurers have been doing this for over a decade. In the past 16 months, Santa Fe Group has met on 3 occasions with CMS. And I must say, they're very gracious. Dr. Madden helped set those meetings up. We appreciate that. They were attentive. They asked good questions. And the 3rd visit, which was just February 2nd of this year, we decided to bring the 3 representatives from those insurance companies. Because it's one thing if a Santa Fe Group member describes the data. It's another thing when someone who's actually administering these programs on a day in and day out basis says, this is what we do, and this is the kind of money we save. And that last visit was very compelling, so much so that at one point one of the physicians from CMMI asked me, Mike, what's the biology behind this? And I was about to go off on how this all happens, and he said, well, you know what, just tell me in a sidebar, because it's very clear that this dental care is making a difference in the total cost of care. Our purpose in visiting with CMS and CMMI was to convince them to do the same kind of studies on their own data that the private insurance sector has done on its data. Okay? Now, so as I don't bury my own lead, if you go and read the Avalier study, it took those first 4, it projected similar results across the Medicare population. And when it did that, it discovered that to deliver the periodontal care benefit over a 10-year period, and they modeled from 2016 to 2025, it would cost $7 billion to deliver the periodontal care. But it would save $73 billion for a net, I'm sorry, $71 billion for a net of $63.5 billion savings. And it grows in the out years. So it saves money from year 1. By year 10, over $12 million net, $12 billion net per year is saved. And for those of you who follow CMMI, they're thumping their chest at $20, $40 million savings. Here's billions of dollars available through dental care being practiced right now in America by the private dental sector and not being seized by our colleagues who are working at the federal level. There are other efforts ongoing. There's a political lobbying effort that's moving forward. I've read a bill that's been drafted. We don't know which end will prevail, if any. But name another issue in healthcare that has the potential to drive that kind of savings. And I'm going to use that to end my comments and say maybe we could even At least we would do the dental care. Thank you very much.
I'm for that. Good afternoon, everybody. First, I want to thank Judy for inviting me to be part of this summit and talk about the need to improve Medicare, particularly audiology services, hearing aids. But before I get into that, I'm glad Ben is still here. I'm sorry I missed your remarks. But if I could just say a couple of things. Every once in a while, the National Committee makes an exceptional hire. And we did that with Ben. And I wanted you to know, and everybody in here to know, how proud we are of everything you've accomplished. And I know you're going to have a continuing exceptional career of service. And I'm looking forward to watching what you do in the future. Now, Ben would be surprised if I didn't mention one thing. And we have a PAC, a Political Action Committee, and a part of, see, he knows, part of, when you have a PAC, you go to a lot of receptions, a lot of breakfasts and lunches and dinners, and Dan has gone to many, Diane, Brenda, you went to some when you were with us. I go to a lot of them. But when we spotted Ben's talent, his charm, and his intelligence, we thought we can use Ben to go to some of these events. And he did. And I have to tell you, we got our money's worth, because we got reports from members of Congress, especially Jim Clyburn, who told me a few times that Ben ate as much as 3 or 4 other people. So that's what he said. And he's so thin. So thank you for everything you've done for the National Committee. So, you know, we know that Medicare has really been a blessing for seniors, and you would be hard-pressed to find a Medicare beneficiary that isn't grateful for the fact that Medicare is there. But there are gaps in coverage, and we've talked about some of them: dental, hearing, vision, and they're especially important when there's a retirement crisis, which we know we have, and there's a burden on seniors to make ends meet. Now, we had Celinda Lake do a study, a poll for us a couple months ago, and it's quite a lengthy poll, but 2 things jump out. 63% of those polled are worried about having enough money in retirement to be financially secure. 65% are worried about the high cost of prescription drugs they can't afford. So the thing is, if you're worried about just getting by, taking care of the necessities of life, you're not going to be able to start paying for things like proper glasses, proper dental care, and hearing aids. 70% of Americans between the age of 65 and 84 need hearing aids and can't afford them. I have some, and I'm lucky I could afford them. This is not just a health issue. As I've said and Judy and I have been working on this for a couple of years now in other settings, this is about safety, not just health. Because if you can't hear the phone ring, if you can't hear an alarm go off, if you can't hear accurately what your doctor's telling you, you're going to have problems. And as you all know, I'm sure we've all had relatives, friends that have had to deal with this, with hearing loss. People start to withdraw from activities, they're embarrassed, and they stop participating in normal activities of life. Now, here's one of the things we've tried to bring into the debate. Judy and I started working with a doctor named Franklin Lynn at Johns Hopkins. He is a clinician, ear, nose, and throat clinician, a scientist at Johns Hopkins. And he has done some groundbreaking preliminary work on the relationship of between untreated hearing loss and how that is linked to early onset of dementia and Alzheimer's. So think about this. If we can convince, as we've been trying to do, members of Congress, the savings that we could realize by dealing with hearing loss, the savings in terms of the costs of treating through Medicare and Medicaid some of these neurological diseases, it would be a no-brainer, as they say. So getting that message across has not been easy, but Judy and I met with Rosa DeLaura last year. She's the ranking on the appropriations subcommittee that funds NIH, because what we need to do is continue the study to make it more definitive. And we've asked Rosa to help us, and I think her heart's in the right place. Well, you've known her forever. And I think this is an issue that really can be a bipartisan issue, because almost everybody I know knows somebody that needs hearing aids and can't afford them. And I really feel we can make some progress this year. Of course, we've got to deal with a budget, of President Trump's budget, his skinny budget that is cutting funding for NIH. So it's going to be quite a hurdle to overcome that. But what Dr. Lin wants to do, and we've been helping him and will continue to help him, is to have enough information. They call it, I don't know what this means, but just randomized clinical trials to test whether hearing loss and hearing aids and other strategies could reduce the risk of cognitive decline and dementia in older adults. So it's a process. I think we've made some progress already. We're trying to find some Republicans who would come on board. So the last thing I wanted to mention is something I've talked about before, maybe even here, but it's to, and I think you mentioned it, Joe, about getting members of Congress to realize that these issues are more than about memos and statistics and numbers. It's about people. So you all know that a couple of weeks ago, or maybe a month ago, we started hearing how the Meals on Wheels program was going to be cut. And it reminded me of an experience when I was staff director of the Senate Aging Committee. And we had a Republican member, I won't say his name, he's still in the Senate, who was not a friend of the Older Americans Act program and thought this Meals on Wheels was a waste of money. But I convinced people in his state to invite him to go along in the van to deliver meals. And he did that. And he came back. He was so impressed with not just the food, that the sustenance of the food, but the human connection. This was sometimes the only person that delivered the meal that someone who's homebound would even have any chance to talk to for a few minutes. He became a supporter. He voted for adding money in the Older Americans Act to the Meals on Wheels program. I think this is a tactic that can be used in a lot of different settings, including hearing loss. So I would love it if someone could convince our president to go to a senior center. There probably aren't many right near Mar-a-Lago, but there's plenty in D.C., plenty of senior centers, and meet with people who need help with hearing aids, as well as a whole variety of things. I had another experience when I was staff director of the Aging Committee. We had a senator who seemed to not be, who seemed to think, and Dan and I have been meeting with some in the disability community just yesterday, I guess. This senator didn't think that there was too much fraud. People were getting all this money, they didn't really need it. So I'm from Omaha originally, and I arranged to have him come to Omaha, and I knew of a man that had been waiting for almost 2 years. He had an appeal in, and we went to see him. And to say he lived in squalor would be an understatement. I mean, he was in a tiny little room by himself. He had to have somebody come in and help him do everything. And this senator, it just hit him. It really hit him, and it changed completely. So, you know, I think these firsthand experiences make an enormous difference. And I know you can't get every member of Congress that needs to be turned around and educated out to do these things, but we should try. We try to do that, and I hope some of you and wherever you are will make that effort, or videos, some way to have make an impression that is beyond just reading a memo or having someone testify, someone like us testify. It doesn't have the same impact. So with that, I'll close, and thank you again for inviting me for the second time. I hope you keep inviting me. Thank you.
I want to thank our panel and just kick off the questioning. We have a few minutes for questions, and I'll start with the topics that Mike, you, and Max discussed. I think you both made compelling cases that if Medicare were to actually cover oral health and audiology, there could be significant savings to the program, in addition to all the moral reasons and anatomical reasons that, you know, the ears and mouth are part of the body and the rest. I was wondering if you have, and Mike, you'd probably be able to provide more insight into this question than Max might in the audiology, because I don't think that issue is as developed as the push to have dental coverage in Medicare. But one of the barriers that was striking to me when I first started looking at this issue is resistance from providers.
Oh, yeah.
Resistance in the oral health world from dentists. It was at, I think, just this very summit a couple years ago. A dentist was present, who's not present now, but I think strenuously objected to the thought of Medicare offering dental coverage, in part because he wanted nothing to do with Medicare. I have a sense that maybe some of that is changing in the oral health world, but Max, I know the same challenges might arise in the field of audiology by hearing aid manufacturers, and I know, you know, the IOM reports and Frank Lin talk about audio assistive devices that aren't as expensive as hearing aids that might be able to do the trick but could cost a lot less, and there seems like there's a room for territory, turf battles, provider battles. Could you comment, both of you, on what you see the barriers here to be and whether or not you think those can be overcome?
So that's a very perceptive question, David, because point in fact is when we started this initiative, we were quite concerned that the American Dental Association, which has one of the most effective lobbying efforts in Washington, I mean top 5 from what I understand, would be against it. The reality is we held a salon to pull these thoughts together last, I guess, end of September last year, and we decided to invite the ADA. We were originally going to sort of go sub rosa, we didn't. And they came at very high levels. The president came, the executive director came, 2 trustees came, and a vice president came. And they got it. They were great. And as we sit here today, I can tell you that the American Dental Association has hired PwC to help them design what a Medicare dental benefit might look like. Now, chances are it's going to be a richer benefit for the dentist than the ones we're working on, but it's, I mean, we can come to agreement that some type of benefit would be meaningful. Even the plan that's being developed collaboratively with Oral Health America is a more generous plan for the dentist than what typical Medicaid dental covers in those states that have dental Medicaid. And the reason we designed it that way is because what's the point of having a plan if no dentist will accept it? So it's not quite what private dental insurance would pay, but many more dentists than take Medicaid would take this plan if it comes to fruition. And one other thing, and this is important, and this might be part of the fact it's helping it. So dental care in the United States, if you look at the demographics, is up in children, thank you, Affordable Care Act, okay? It actually is up a bit in the geriatric population because that's the baby boomers retiring, many of whom are reasonably wealthy and can buy their own dental care. But the other side of the spectrum is very ugly. But here's the news. Between 18 and 65, dental services to the American population have been dead flat for 9 years. There's no growth. There might have been a little growth last year, not clear yet. So I think the profession is realizing it might be pretty good if 30-odd million people can now begin to access care.
So it's really a good question, but keep in mind when Medicare, when people worked on creating Medicare, who opposed Medicare? The doctors. They didn't want to deal with it. They didn't want to deal with the rules and the regulations. So it's no surprise, and that took a long time to overcome, and a lot of compromising to overcome that opposition. So it's no surprise at all that some of these associations haven't seen the light yet. I've talked to people with the American Dental Association. I was shocked, because my argument is, yes, you might have to deal with some reimbursement issues, but think of all the business that's out there. Forget about the moral imperative. Think about all the business. And but couldn't get anywhere. And in my own experience, when I got my hearing aids, it was about 2 years ago in Maryland, and the woman that I dealt with was so nice, so compassionate. I thought, well, I'll ask her. In fact, I wanted her to come to some of the meetings we were having with Debbie and Debbie Dingle, and with Rosa and Dr. Lynn. She said, I'm not really for that. I don't want to have to, I wouldn't be for Medicare covering that. It's just too complicated, too many problems. So it's a big hill to climb. No question.
Thanks, Mike and Max. Joe, I have an rather unfair question for you, given that down is up is down, cats are dogs. We don't know what day it is, what week it is, but given the events of last week, do you think the Bennies Act has a better chance of passing, as less of a chance of passing, or can we pin our hopes on some very good bill that will help a good number of people getting through?
I really don't know. I do think there's some renewed interest. We've seen that. Stacy has talked with some folks this week about it, about reviving it and getting it going again. So I think that once again, we're saying all the same things, and it's true with Allie's work as well. When you talk to legislators and staff on the Hill, they've all had these problems in their own families. This one particularly in the enrollment issue, you don't really have to come up with horror stories about people that are, not that well educated at the low end of the income scale. I'm talking lawyers and professionals and, and senators, that have had this problem, or senators' mothers that have had this problem. So I think there is a lot of support for it. I think, once again, it's, if we get an extenders bill that has the therapy caps in it, et cetera, this could be part of it. Or I think, we would be happy for it as a standalone, but I think as a standalone it would mean they're really not getting anything else done. Because, this is, not a big bill. We think it's a big deal, and it will help millions of people with Medicare every year. There's about 1 million people that are paying a Part B penalty, so, but if it happens by itself, it will be, okay, we need to get something done, and this is a bipartisan, way to do it. But to go back to the money thing, right, because we're all talking about money, the reason these things aren't happening, the biggest pushback we got on the bill is because it scored like what, Stacey? 50 million. 50 million it scored because of the notices, and people wouldn't be waiting. Those sick people that wait till July 1st come along to get treatment, they might actually live longer and get more treatment if they got it, starting on February 1st, and actually live to see their Medicare benefits start. So that costs money. So that is the kind of mentality you're dealing with here, and I think it's outrageous. I think it's outrageous that, we have to say, oh, by the way, giving people dental care will save money, or people giving, but we do. I mean, that's the name of the game, unfortunately, So finding those pay-fors for this is hard. We'll take a little bit of the dental money, okay? Well, we only need 50 million. Chump. So I think that's unfortunately the world we live in. I think we will have opportunities to get things done in the context, we have to be ready for them. All of the research and the stuff that we're putting into play, we need to be as opportunistic as they will be, is I guess what I would say, because there are going to be those moments.
All right. Please, everyone, join me in thanking our panel. Once again, thank you, all of you.
What a day, what a wonderful day. Thank you all so much. Maybe we can get an observation bill that has the Benny Act component, oral health, and audiology. And I can tell you, being a member of the tribe, and my mom, the same person who we had to do Medicare appeals in order to get her PT to continue, who's still walking only because of that, isolates when she can't hear. And she finally has hearing aids, and we know this all firsthand, and all members of Congress. So I'm serious when I think, what bill can we put together? And Sherrod Brown talked about observation with the new administrator at her hearing. She said she wanted to improve it. We're going to try and take her up on that. And Toby and I meet in a couple of weeks. And I'm serious that I think this might be and stick on some therapy caps, and then think whether that's smart or not. But I think that, as Senator Rockefeller said, this is a time for ardor, determination. And in part, if I start to say, well, I don't know, would that be, maybe we shouldn't do that because that's the way they behave. And someone needs to remind me and each of us that we're fighting a good fight here, and we need to sometimes be, what's the phrase, as tough as as kind as you can be and as tough as you have to be in order to get our work done.